Welcome to our first video on diseases of the colon. Let's get started. Here's an overview of what we'll be covering in this lecture. So we'll be covering colonic polyps and colorectal cancer. So let's start with the polyps. Colonic polyps can be divided into neoplastic polyps, which require resection and or close surveillance. And it can also be divided into non-neoplastic polyps, and those are less concerning. So the neoplastic polyps can be subdivided into adenomatous polyps and serrated polyps. You may recall from step 1 that adenomatous polyps are gland-like outgrowths of the colonic mucosa, and they can be referred to simply as adenomas, whereas serrated polyps are characterized by the sawtooth appearance of their surface. And that makes sense. Serrated, sawtooth. Well, the non-neoplastic polyps include hyperplastic polyps, which are formed just through hyperplasia of the colonic mucosa. Next, we have hamartomatous polyps, and those are formed by disordered growth of the mucosa, and it can be associated with Peutz-Jeghers syndrome or juvenile polyposis. Another non-neoplastic polyp are inflammatory pseudopolyps, and those are found in ulcerative colitis and are formed by regenerative mucosa. And another way to characterize or categorize non-neoplastic polyps are mucosal and submucosal polyps. Now, the most clinically significant are the adenomatous and serrated polyps, and that's because they have neoplastic potential. Now, let's take a look at this endoscopic image of an adenomatous polyp. You can see that it's basically just an outgrowth, an adenomatous outgrowth, of the colonic mucosa. And here's another endoscopic image showing a serrated polyp. Here's a gross image of a tubulovillous polyp. Now, this is a type of adenomatous polyp. And note that it has this pedunculated appearance with a central stalk. And you may recall from step 1 that a tubulovillous polyp can have intermediate potential of malignancy. Now, this is a gross image of a villous polyp. And you may recall that these are adenomatous polyps that have a high potential of malignancy. Now, in adenomatous polyps, factors that favor increased risk of developing colorectal cancer are large size, specifically 1 centimeter or more, a large number, that is the presence of 3 or more concurrent adenomas, so in other words, huge or multiple, or a villous morphology, and that over a tubular morphology. So villous worse than tubular. And lastly, a sessile appearance is more concerning than a pedunculated appearance. Okay, now let's come to our next topic, colorectal cancer. Now, the topics we'll cover during our discussion of colorectal cancer are the epidemiology, the risk factors, the different subtypes you need to know, as well as how it clinically presents, and then, of course, how you work up, manage, and screen for it. So let's start with epidemiology. Colorectal cancer is the 3rd most common cancer of adults in the United States, and it's the 2nd leading cause of cancer deaths among this population. And the peak age of incidence is between 70 to 80 years old. Now, the etiology of colorectal cancer is multifactorial. It has both genetic and environmental factors that can contribute to its development. Since the majority of colon cancers occur in people older than 50 years, age is actually the most important risk factor, and any patient with age greater than 50 years is a candidate for screening. In addition, people who develop colon cancer once are at risk to develop it again, and hence a personal history of colorectal cancer or adenomatous polyps is also a major risk factor. Remember those 2 giant categories of neoplastic polyps, or adenomatous and serrated? So if you have adenomatous polyps in your past, or serrated for that matter, then your risk of getting cancer is pretty high. Now, although colon cancer occurs mostly in people over 50 years of age, it can be found in younger people. And those people are usually those with familial colorectal cancer syndromes, or those with chronic inflammatory states such as inflammatory bowel disease. So we're thinking Crohn's disease or ulcerative colitis. Lastly, a diet deficient in fiber and rich in total fat and red meat is a risk factor. Now, next, we're going to discuss some highlighted subtypes of colorectal cancer. Those include colorectal cancer associated with inflammatory bowel disease, familial colorectal cancer syndromes, so that involves familial adenomatous polyposis, Lynch syndrome, Peutz-Jeghers syndrome, and familial juvenile polyposis coli. And lastly, we'll talk about colorectal cancer associated with two different types of bacteremia, Streptococcus gallolyticus and Clostridium septicum. Please note that patients with familial colorectal cancer syndromes are born with mutations that significantly predispose them to developing colorectal cancers. And those patients can develop colon cancers at much younger ages than the general population. So screening for those patients begins much earlier. Again, the hope is that you would know that they have that genetic condition so that you know to screen for it younger than the standard age of screening. So now let's address the IBD-associated colorectal cancer, or those associated with ulcerative colitis and Crohn's disease. So the risk of colon cancer is increased in both of these conditions. However, ulcerative colitis confers a greater risk compared to Crohn's disease. And the risk is increased with the duration. So the longer the patient has the disease, the greater the risk of developing colon cancer. And strangely enough, the duration of disease does not mean how long they've had symptoms, because you can have ulcerative colitis and be very symptomatic and then go into remission, but they still have ulcerative colitis. So the clock is still ticking and bringing them ever closer to increased risk of colon cancer. Now, colonoscopy with mucosal sampling is to be done every 1 to 3 years, starting 8 to 10 years after the initial diagnosis. Again, you're going to do that testing regardless of whether or not they've been having symptoms this whole time. And then if dysplasia is detected, you're going to do a colectomy. The risk is that high. Now let's continue with familial adenomatous polyposis. So this is caused by an autosomal dominant mutation in the APC tumor suppressor gene. As the name suggests, this syndrome is characterized by hundreds of adenomatous polyps, and those develop in the colon, and they start at puberty. And with each adenomatous polyp, there's an increased risk of developing an invasive colorectal cancer. And since there are hundreds and thousands of these polyps, at least one of those will eventually develop into a full-blown colorectal cancer. Therefore, we see a 100% progression to colorectal cancer by the age of 40 in these patients. Now, some patients with this syndrome also have osteomas and desmoid tumors. And if they have that, you actually call this Gardner syndrome. Whereas if they have concurrent brain tumors with the familial adenomatous polyposis, you call that Turcot syndrome. Now, this is a gross image of a resected colon in a patient with familial adenomatous polyposis. And note that you can see numerous small polyps throughout this entire section. So when you're looking at this, you can see so many, and odds are just favoring colon cancer. At least one of those will develop into cancer. Now, since these patients can develop colorectal cancer anytime after puberty, annual colonoscopy is performed, and that's starting at age 10 to 12 years old. Now, an urgent proctocolectomy is performed if colorectal cancer or any high-grade adenoma is detected. Also, screening for upper GI tumors is recommended, since patients with this condition have an increased risk of developing even those types of tumors. But we're not just dealing with colon at this point, you're thinking upper GI. So be on the lookout. Lastly, genetic testing for the APC gene mutations can be performed to confirm the diagnosis of familial adenomatous polyposis. Now, Lynch syndrome is another high-yield familial syndrome linked to colorectal cancer. It can also be called hereditary non-polyposis colorectal cancer. And you may recall from step 1 that it's caused by an autosomal dominant mutation in DNA repair genes. That's MSH and MLH. And ultimately, that mutation leads to microsatellite instability. The inability to correct errors in DNA nucleotide sequences can lead to a buildup of DNA mutations in various tissues, putting these patients at a high risk of developing a number of different cancers, which of course includes colorectal cancer, but it also includes skin cancer, endometrial cancer, and ovarian cancer. Now, in contrast to familial adenomatous polyposis, there's actually an absence of adenomas in these patients. Now, all patients known to carry this mutation are required to undergo colonoscopy every 1 to 2 years, starting at age 20 to 25 years. And note that the initiation of colonoscopy screening is more delayed in patients with Lynch syndrome compared to the disease we just discussed, familial adenomatous polyposis. Recall, in that condition, you start annual colonoscopies at puberty. Another important point is to remember that women with Lynch syndrome also require annual endometrial biopsies starting at age 30 to 35 years, and that's to detect early lesions of endometrial cancer. All right, now let's try a question. An 8-year-old boy is brought to the physician by his parents for an annual well-child visit. His father and uncle were diagnosed with colon cancer at the age of 30 and 28, respectively. Genetic testing of this patient's father reveals mutated APC gene. The patient's mother is healthy. What are the appropriate screening recommendations for colorectal cancer in this patient? Okay, so the father and uncle of this patient were diagnosed with colon cancer at the age of 30 and 28, respectively. And this is a very young age if we're talking about just sporadic colorectal cancer. So, genetic testing of the patient's father revealed a mutated APC gene. That was a logical thing to do for that clinician. And that finding confirms the diagnosis of familial adenomatous polyposis. And remember, this is an autosomal dominant disease. Therefore, the patient has at least a 50% chance of having inherited the mutated gene. And colon cancer screening recommendations in patients with a family history of this are colonoscopy every year starting at puberty, where you can say 10 to 12 years of age. So in other words, this 8-year-old boy had a father with a mutated APC gene, so he himself needs to get ready for colonoscopies in a couple years. Now, Peutz-Jeghers syndrome is characterized by hamartomatous polyps throughout the GI tract. And recall that hamartomatous polyps are formed by disordered growth of native tissue, and they themselves are not malignant. However, these patients have been shown to have an increased risk of developing colorectal cancer and various other GI cancers. In other words, if you see a hamartomatous polyp, you're not thinking that the hamartoma is actually dangerous itself. It just makes you worried about what else might be going on. Now, in addition, these patients have hyperpigmented macules on the lips, the hands, and the genitalia, and those are another good clue in the diagnosis of Peutz-Jeghers syndrome. So let's take a look at an image of a patient diagnosed with Peutz-Jeghers syndrome. And we can notice the hyperpigmented macules on the lips, which is strongly associated with this condition. Now, familial juvenile polyposis coli is another syndrome associated with increased risk of colorectal cancer. And these patients develop numerous hamartomatous polyps in the colon before 5 years of age. And these patients have a slightly increased risk of colorectal cancer. Now, Streptococcus gallolyticus and Clostridium septicum, those bacteremias associated with those bacteria, have a strong association with colorectal cancer. So, colonoscopy is indicated in all patients with Strep gallolyticus, formerly known as Strep bovis type 1. And the same is true for Clostridium septicum, or endocarditis. And I want to emphasize that this colonoscopy is recommended even in the absence of a prior or current history of colorectal cancer. In other words, bacteremia with either of these pathogens is enough of an indication to get a colonoscopy. Now let's move on to clinical presentation. So in most colorectal cancers, they're largely asymptomatic, at least in the early stages. Now, symptoms develop during advanced disease when the tumor is large enough to cause local bleeding or mass effects. And that means that a considerable delay in diagnosis can occur. And that's, of course, in the absence of regular screening. So, hence the importance of screening before symptoms. Okay, so all colon cancers can produce obstruction, bleeding, and systemic signs such as weight loss and fatigue. However, because of differences in the luminal diameters of right and left colon, the different clinical manifestations are generally seen with right-sided and left-sided cancers. For example, tumors in the right colon can grow into bulky exophytic masses due to its large caliber without causing any obstructive symptoms or changes in bowel habits. Now, eventually, they can start causing local bleeding and/or systemic signs. So the point is, right-sided colon cancers typically present with occult bleeding in stools or melena. And I want to emphasize occult, meaning it's not super obvious. And hopefully, for the sake of the patient, they can see some melena because that will trigger some concern to get this looked into further. Weight loss can also occur due to the tumor cytokine effect. Now, I just want to emphasize this iron deficiency idea one more time. So, iron deficiency anemia in an elderly male is to be considered colon cancer until proven otherwise. So this should be a red flag, and you're going to want to be thinking about colon cancer and colonoscopy. Okay, so that was right-sided. Now let's talk about left-sided cancers. Now these on the left side typically grow as infiltrating masses that encompass the whole lumen. And those produce obstructive symptoms because of the small caliber of the left colon. In other words, the tumors don't need to get quite as big to cause problems. So they present with acute, complete large bowel obstruction, commonly seen as an apple core lesion on imaging. They can also present with a more chronic, gradual change in bowel habits, causing alternating diarrhea and constipation and pencil stools. And the cancer may also bleed, causing fresh blood or red blood in the stools. And that's known as hematochezia. Lastly, rectal cancer commonly presents with hematochezia, as well as tenesmus, which is a feeling of incomplete evacuation of stools, and or rectal pain. And that's logical. It's on the rectum can hurt. Because it's there where your stool would be, then it feels like you're not getting everything out, which is true because the cancer doesn't get evacuated with your bowel movements. Now let's take a look at this image of a barium enema in a patient diagnosed with colorectal cancer. Now it shows the characteristic apple core sign that results from an obstructive effect of a neoplastic mass. So how do you work this up? Well, the investigation of choice in a patient with suspected colon cancer is colonoscopy with a biopsy. And the biopsy enables one to confirm and characterize the type and grade of the cancer. And after confirmation, staging of the cancer is required. And for this, to stage, the most widely used investigations are CT scan of the chest, because you're looking for lung mets, and CT of the abdomen and pelvis, as well as liver function tests to rule out liver and other abdominal and pelvic organ metastases. In addition, you also want to assess the level of CEA tumor marker, and that stands for carcinoembryogenic antigen. And that doesn't play a role in screening, or else we would have mentioned it, but it does play a role in the follow-up of the cancer after curative treatments are attempted. Now, before I go any further, I just want to mention that this image was contributed by Amboss. So thanks to our partnership with Amboss, I can highlight some important features of colorectal cancer. So here we can see an irregular exophytic mass, and that is suggestive of colon cancer. Now, a biopsy is required in this case to determine the type and grade of the suspected cancer. Now, the management is fairly intuitive because it involves removing the cancer. So surgical resection of the affected bowel segment is the treatment of choice. And this is also the best palliative therapy in patients with advanced incurable disease. And this surgical resection is accompanied with lymph node dissection. Now, for advanced disease, adjuvant chemotherapy and radiotherapy is indicated. Okay, so now after resection and or chemoradiotherapy, then tumor recurrence is monitored through those various means we discussed. For example, a CEA tumor marker, and then follow-up colonoscopies. Now, specifically, a colonoscopy is to be performed at 1 year after resection, and then every 3 years after. Now, before we end this section, let's discuss the screening for colorectal cancer. Now, the importance of screening is illustrated by the fact that virtually all colorectal cancers arise from adenomas, which are not cancer yet, and then they progress from that stage to invasive cancer. And that takes about 10 years, giving you plenty of time to catch this if you're screening. And the idea is to resect those adenomas before they have a chance to do anything nefarious. So the mortality for colorectal cancer decreases significantly if appropriate screening protocols are applied. And there's a number of screening methods to actually use today, and each of them with their own sensitivities and specificities. Now, the most sensitive and specific is colonoscopy. So that's the investigation of choice. However, a flexible sigmoidoscopy can be considered a reasonable alternative. Additionally, there's even less invasive methods, such as a fecal occult blood test or a fecal immunochemical test. You might see these abbreviated as FOBT or FIT, respectively. There's also CT colonography, and those are available to patients who basically don't want a colonoscopy. But again, they're not as sensitive or specific. So when do you start all this screening? Well, as we already discussed, all adults above 50 years of age are at increased risk of developing colon cancer. And so that's true even in the absence of any family history or specific risk factors. So all individuals should undergo routine screening starting at age 50. And again, the preferred screening is a colonoscopy, and you do that every 10 years. And the reason this is so effective is because it allows the doctor to see the whole colon and the rectum for any polyp or ulceration or mass or anything out of place. And recall that the development of invasive colon cancer from its precursor lesions takes about 10 years. So if you have a good colonoscopy at age 50, or a normal one, then you don't need to repeat it until 10 years later. But what about patients who just don't want a colonoscopy? Well, you can offer something called flexible sigmoidoscopy. Now, compared to colonoscopy, it's a simpler procedure, and it requires less bowel preparation, and it doesn't require sedation. So for those reasons, patients sometimes will go for that instead of a full-blown colonoscopy. However, it only visualizes the distal colon, so you're not really seeing the right side of the colon. However, since 2/3 of colon cancers actually arise in that distal segment, it's actually a reasonable alternative if done every 5 years. And that's something to mention to patients. They have to repeat this every 5 years instead of every 10, and it only catches 2/3 of the cancers that can arise in the colon, because after all, 1/3 of those cancers are going to be in a location not visualized by the flexible sigmoidoscopy. Now, other non-invasive alternatives, such as those fecal tests that we talked about, are also available. And those, because they're obviously not as ideal, not as sensitive, not as specific, you need to do those every year. But a lot of patients will go for that. If they don't want a colonoscopy, you can say, okay, we just need to test your stool every year. However, if they get a positive test, they need to get a colonoscopy. So we just discussed screening in everybody, meaning those who don't have a strong family history of colon cancer. Now let's talk about if the patient does have a positive family history. Well, first let's define it. So a positive family history is defined as the occurrence of colorectal cancer or adenomatous polyps in one or more first-degree relatives before age 60. You could also define it as the occurrence of colorectal cancer or adenomatous polyps in 2 or more first-degree relatives at any age. So for patients with a positive family history, colonoscopy is to be performed every 5 years starting at age 40, or 10 years before the age of diagnosis of their relative, whichever comes first. Now let's discuss an example to make sure this is clear. A 25-year-old woman comes to the physician for a regular checkup. She has no specific complaints. The vital signs and the physical examination are unremarkable. The patient's father was diagnosed with colon cancer at the age of 45. When should colonoscopy screening be started in this patient? So as we discussed already, colonoscopy in a person with a positive family history, like in this case, is started at age 40 or 10 years prior to the age of diagnosis of their relative, whichever comes first. With that in mind, we get 2 options to either screen the patient at age 40 or at age 35, which is 10 years before the age of diagnosis of her father. And since 35 comes before 40, the correct screening age in this case would be 35. Now let's end this section with a board-style question. A 69-year-old man comes to the physician due to fever and shortness of breath for the past 3 weeks. He has no cough. He has been smoking 2 packs of cigarettes per day for the past 50 years, but he does not drink alcohol or use illicit drugs. His vital signs are significant for a temperature of 39 degrees Celsius, a blood pressure of 135/80, a heart rate of 110 beats per minute, and a respiratory rate of 15 breaths per minute. The physical examination shows a pansystolic murmur at the apex radiating to the left axilla. There are linear hemorrhages under the fingernails. A transesophageal ultrasound shows large vegetations on the mitral valve along with mitral regurgitation. Blood cultures are positive for Clostridium septicum. Which of the following is the best next step in the management of this patient? A. Chest CT, B. Abdominal X-ray, C. Colonoscopy, or D. Sigmoidoscopy. Okay, so this man presents with fever and shortness of breath for the past 3 weeks. The physical examination shows a pansystolic murmur at the apex radiating to the left axilla, and there are linear hemorrhages under the fingernails. So this is all pointing us towards something. And a transesophageal ultrasound shows large vegetations on the mitral valve along with mitral regurgitation. So all of those findings suggest subacute bacterial endocarditis. And ultimately, the main clue was that his blood cultures were positive for Clostridium septicum. Now, when bacterial endocarditis is caused by either Clostridium septicum or Streptococcus gallolyticus, then you're going to suspect underlying colon cancer. And that's because invasion of cancer deep into the colonic mucosa can introduce that bacteria into the bloodstream, causing sepsis and endocarditis. Now, in order to screen for colorectal cancer, one should order a colonoscopy. So the correct answer is option C. Now here's the slide reminding us of the association of Streptococcus gallolyticus and Clostridium septicum, and how bacteremia with those pathogens is associated with colorectal cancer. So now let's discuss why the other options are incorrect. Now options A and B are incorrect because a chest CT and abdominal X-ray are not helpful for detecting colorectal cancer. Finally, option D is incorrect because sigmoidoscopy allows for inspection of only the sigmoid colon, and you're only going to use that as a screening tool. And again, it's not as ideal as the colonoscopy. After all, the colorectal cancer in this patient may be anywhere along the colon, so you need to do the full colonoscopy. And that concludes our lecture on colonic polyps and colorectal cancer.